Dear colleagues, I want to share with you interesting case from my private practice. A patient was referred to me because of sinus tract and some pain in area of upper lateral tooth. On examination, I find the sinus tract, and you can see here tracing X-ray. Percussion is slightly positive. Palpation slightly positive, cold test positive, okay? And also we can see some radiolucent area, no pockets, by the way. It's interesting that we have sinus tract, we have lesion, and we have positive cold test. I think sometimes dentists during the tracing X-ray can mask some structure inside of the tooth, and I think that we need as a diagnostic X-ray, two X-ray, one with a tracing and second without the tracing. And when I did a second X-ray without the tracing, I understood what I have here. What I had here is rare anatomical situation. It's dense and dental, classic in upper lateral. And of course, when we have a complex anatomy, it's a reason for a CBCT scan. Okay, here we see very well this dance. Okay, maybe now after that you see without tracing, you can see it with tracing, but it's difficult with gutta percha inside of sinus tract. What we can see and what we can understand from CBCT. First of all, we can classify this type of dense indentum. Till now, we use a classification of Ohlers from 1957. And in this specific case, because we see a different opening, lateral opening of dense, we know that we're speaking here about Ohlers 3A. But what's very interesting here in this CBCT scan, that this CBCT scan can give us the answer why we had positive cold test. Of course, one possibility is false positive. It's happened. But in this specific case, please see now this scan, and suddenly you understand that we have no lesion on apex of main canal. All these lesions from the dance. And by combining all these data, I have a very nice diagnosis, a different one for the main canal and for the dance. In main canal, vital pulp and normal periapex. In dance, necrotic tissue. I can't wrote here, right here, excuse me, necrotic pulp tissue, because I have no idea what type of connective tissue we have inside of the dance. We have different histology, but it's some necrotic and infected, of course, tissue and chronic apical abscess. And because we have this type of diagnosis, we can choose a very nice approach, selective root canal approach. Firstly, by the way, described in literature in 1987 by my teacher from Tel Aviv University, Professor Ariel Kaufman. This is what I did, okay? First of all, I use an CBCT to understand where I must go with a small excess cavity, and I did it. You can see that I did it is a very special bore. I like this bore very much. This is a bore done by SS White Company and a guide bore. And I did this small excess cavity, and I find finally the canal. The canal was very small and very tight. You can see that all of this canal is from enamel. It's what's very difficult to work inside, and it was very difficult for me to go to the working lengths. Okay, just with the time I was successful to go to the working lengths, and little by little, I prepare it with control memory wire instrument with a small taper, maximum 0.4, okay, up to number 30. During this preparation, in this infected tissue, I use a combination of NOCL and HEDP. And in this specific case, because of problem of this patient, after my visit, he had to flight, and I finish this case in one visit. Personally, in most of cases that I work with chronic apical abscess, I prefer to visit with calcium hydroxide to check the sinus tract is closed. But in this specific case, I finish everything in one visit. And what it's nice that I have now follow-up, 6-month follow-up, no sinus tract, cold test continue to be positive, and with the healing lesion. Okay, very, very nice situation, a very interesting case, and I think that definition of selective root canal treatment, it's appropriate to this specific case. Thank you for your attention.